What I'm here to talk about is how I perceive the evolution of this precision medicine field, particularly in the UK, over the past 20 years. But the truth is, I'd really like to start about 600 years ago, because this is really, I think, illustrates the problem that we're trying to solve with precision medicine. And this is a list of the people who died in London in a single week in the 16th century. And you can see this is the terminology of the diseases that they died from. So this was essentially the coroner saying, what did all these people die? And as a result, it's a sort of lexicon, a taxonomy of disease, as it was in these early stages of medicine. And the first thing that becomes immediately obvious is that it's almost impossible to recognize any of these terms. You wouldn't find many of them in a textbook of medicine. Well, cough you do find, but you don't find that cough usually kills 18 people. Apoplexy you've heard of, and bleeding. But there are lots of other things here which frighten, gout, grief, griping of the guts, a whole variety of different disorders. And I think what that reveals is very important, and that is the medical profession has, throughout its history, done its best to have a taxonomy of diseases based on what the patients complain of and what they see at the bedside. But in reality, that's created many advances in medicine, but it's also created a system which is innately inefficient, because many of these things disguise mechanistic disorders which are different than the pure symptomatology or what you see at the bedside. And in a sense, we're now moving, largely powered by this enormous engine from genomics, into an era when we can define our diseases much better. Great. So now you might think, well, the medical field has moved well on from the 16th century, so what's he on about? But I would argue that disease taxonomy today is equally confusing. And one of our problems is that we're not entirely sure how to describe diseases. And there are a number of different methodologies for that. One is to use, again, the symptoms of a disease. And here, the two examples, the so-called irritable bowel syndrome, which is exactly as it sounds, and that is people who have, in 16th century parlance, griping of the guts. That's irritable bowel syndrome, or fibromyalgia. We've got pathologists who are essentially doing the same thing, looking down microscopes and describing what they see. And they produce these very flowery terms like angioimmunoblastic lymphadenopathy, which is essentially lymph nodes with a lot of blood vessels and big lymphocytes. Doesn't really tell you anything about the disease etiology. Physiological definitions of disease have their own challenges. These are normal distributions of things like blood pressure and diabetes. What's a disease? Where do you draw the line? It's almost entirely arbitrary. Doesn't really tell you anything about disease mechanisms. And then there are, of course, eponymous terms. So Alzheimer's disease and Bell's palsy, these are, again, described after the person who originally described them. That's not me, incidentally. But you know, what typifies the problem, if you go back to Alzheimer's original paper where he described 6 patients with the disease, it now would appear that about half of them didn't have what we now call Alzheimer's disease. So there are problems with that methodology. Obviously, there are also organ-based methodologies. This is particularly in cancer, and you can see the kind of problems that you get into purely defining the disease based on where the lump is rather than what the molecular mechanisms are, and we all know how that emerged. And then what I call the end-of-the-road diagnostic category, which is commonly used in hospitals, and that is clinicians will also identify the organ that's falling over and add the term failure after it, and that's ultimately the diagnosis. So you have heart failure, liver failure, ovarian failure, premature ovarian failure, so on and so forth. So the reality is that this is a mess, and because it's a mess, the healthcare system doesn't work very well, because each one of these rather fuzzy diagnostic criteria mean we don't treat people with the right drugs, we don't really understand the natural history. The whole healthcare system, as Eric rightly said, we spend a lot of money treating everybody as if they had a particular disease rather than concentrating our resources on individual subpopulations. And Thomas Lewis in 1944, I think, really said this beautifully in a series of monographs that he produced. And here's one quote out of that. The idea that many diseases are fully understood is an illusion. This may readily be apprehended if one goes into a general hospital ward and we ask ourselves the simple question, as we pass from one bed to another, why is this person suffering thus and we are not? Only rarely can that simple question be answered. We clearly understand a phenomenon here and there. Those we think we understand become our pride and bulk largely in our consciousness. Those we do not understand, we conveniently ignore, or more often we give them names and deceive ourselves that we understand them. So, not surprisingly, Regius Professor is not very popular with the medical profession, and as you walked in the front door of the museum, you would have seen perhaps on the left, there's a little door that says Office of the Regius Professor of Medicine. They used to put the Regius Professor of Medicine in the museum, partly because of their age, and partly because they had to keep them as far from patients as they possibly could. And that applies to this day. So some of my experiences in this whole area of personalized medicine emerged from my exposure to the commercial sector, because in the commercial sector, the ability to actually be commercially successful making drugs is in part determined by your ability to make good drugs that work highly effectively in the patients they're administered to. And I've now been on the Roche board for almost 15 years, but the experience there has been hugely helpful and partly driven by my exposure to these three people. This person, Sue Desmond-Hellman, was the head of development at Genentech, and she was a real pioneer in this field of precision medicine, and in fact chaired the Precision Medicine Committee that wrote the report for the IOM, and was clearly focused on that issue. And this guy here, Art Levinson, who was the chief executive of Genentech for many years, and then the chairman of the Genentech board on which I sat, had similar passionate views about targeting medicines, and it was from that stable that drugs like Herceptin and the likes emerged. And this guy here, we're going to honor tonight. This is Jonathan Knowles, who was the head of group research at Roche and Genentech, and was, I think, one of the great pioneers in industry of saying, you've got to define the disease before you start developing the drug, and the two things go hand in hand. And now, in the combined group, 70% of the drugs in the pipeline have companion diagnostics associated with them, which I think is the direction of travel for the industry. And the reason it has to be the direction of travel for the industry, I think, is really well illustrated here. And to be clear, this is data from EFPIA, which is the European Pharmaceutical Industry. So this isn't my data, it's their data. And what it shows is the problem in healthcare. This is why all healthcare systems are bust. And the reason is, if you look at response to drugs in each of these major classes, you can see in dark blue over here the non-responder population, which basically means they have different disease. And for antidepressants, that sits close to 40%. For asthma drugs, it sits on 40%. Diabetes, closer to 50%. As we know, the novel arthritis drugs, it sits at 50%. Alzheimer's disease at 70%. And of course, cancer is even more hopeless at 70%. So if there was an argument to make to politicians and people who run healthcare systems as to why we need to do this, that's the argument. Because we can't continue to run a healthcare system which is as inefficient as that. Now, what are the key components that we need to have to create a precision medicine strategy? And you've heard, I think, a beautifully articulated Eric's strategy from the US, and it's not a million miles different from where I think we thought we needed to get. And in a sense, one needs, first of all, this new disease taxonomy, which drives the development of new therapeutics and allows us to more precisely target our medicines on particular patient subgroups. And that's been greatly facilitated by the new diagnostics, genomics, but also things like imaging that allow us much more precise interrogation of patient populations. But in addition to that, we need to access, through electronic records, disease phenotypes, outcomes, therapeutic responses. And we also have to use some of these device methodologies to allow us to get real-time data on how patients are responding, what they're doing, what they're being exposed to, and so on. And all that information, as Sue so elegantly put it in her report, needs to sit in what we need to call an information commons. And that commons needs to hold all this data so it can be analyzed and interrogated in a whole variety of different ways. And that's actually the optimal outcome of where we're trying to get to. And it's clearly the agenda which the Precision Medicine Initiative in the US has got, and it's certainly the agenda here in the NHS with the various initiatives that we've launched here. So just to go back again on history, and again, this is not going to be 20 years, it's going to be much longer, but there is a really interesting history of this, which goes back quite a long ways, and I think it's wholly appropriate that this meeting's being held in this building, because in many ways, the underpinning theoretical basis for a lot of what we're doing came from this guy whose case was argued so eloquently in this building 150 or 175 years ago. But then subsequently, there were some really fundamental insights that I think changed the way we thought about the genetics and disease. And Archibald Garrett, who'd done beautiful work on single gene disorders, was in fact the first person who put together this notion that the genes interacted with the environment for most of the major common diseases. And it was that interaction that you needed to get to the bottom of if you were going to understand mechanistically what was going on in disease. Of course, we had Watson and Crick in the discovery of DNA in Cambridge. Fred Sanger, the same at the LMB in Cambridge. Alec Jeffreys did mini satellites. Ed Southern did arrays. These are all really substantial advances in the field of genetics and genomics that have taken the field on so dramatically in the past 50 years. And then more recently, going back 25 years, the Human Genome Project, which was a major breakthrough project, followed rapidly by work on the HapMap, and then the first systematic approach to defining variation around the genome. The Wellcome Trust Case Control Consortium was, in a sense, the exemplar, the pilot study, the major pilot study for whole genome-wide association studies led by Peter Donnelly, began to have an impact on our understanding of the maps for common disease. Then the dramatic advances in next-generation sequencing, and then UK Biobank, which was a project that was conceived many years ago, but powerfully implemented by Rory Collins and Tim Peatman and others who will be talking to you tomorrow. And then the ability, finally, after this very long journey, to deliver something to patients, which is essentially genome sequencing in the clinic, which John Chisholm will be talking to you about this afternoon. So it's a remarkable story and a remarkable journey going back many years, but you can see how one project led on to another. And I think, having been very intimately involved in many of these projects at the strategic stage, one of the messages is that if you only did things you knew you could do, you wouldn't do anything. Because all these projects, including the Genome Project, when the Genome Project was started, we had no idea we could do the Genome Project. We had no idea that this was going to work. We had no idea that that was going to work. And we certainly had no idea that that was going to work. But if you wait till it's all really obvious, then you're going to miss the boat. So I'm a real believer in starting projects where there are technical challenges and other challenges, but you've got to get going, otherwise you'll never get there. And getting these things launched, I think, is one of the great successes that's had huge political support in the UK, as it has clearly in the US. So this is actually Eric's map of the GWAS hits around the genome. Of course, there's a long catalog of this going back a long way, and it's now got so dense that you can't really map the hits anymore. But the point I wanted to make is we already know an enormous amount about genetic variants that drive disease, and almost every common disease has a host of these genetic variants associated with it. And I think what's interesting is that the industry in general has been rather slow to take advantage of that, but I think that is accelerating pretty steadily now, and people are being much more active at using these as a starting point for the discovery of new drugs, which ultimately are likely to be more successful. And I'll just show you one example, because it goes back to the first major GWAS hit that was advertised and published in Science many years ago, and that was the identification of the role of factor H in dry macular degeneration, or actually macular degeneration now, but largely dry macular degeneration, where it was clear that the activation of the alternate complement pathway was clearly involved in the disease. And what that's now led to is a set of really interesting drug development projects, and one particularly on complement factor D, which is the limiting factor, the limiting enzyme in this alternate pathway. And antibodies to that turn out to have quite a dramatic effect on the progression of geographic atrophy, which is that abnormality you see in the back of the retina. And this is an improvement, a reduction in geographic atrophy control in treated patients in a study. This is a Genentech drug. But when you actually then target that in people who've got the complement-related biomarkers, you can see an even more dramatic effect. So the idea that you're going to develop a drug and not target it at people in whom that pathway is really active, most people say, well, that's crackers. Well, to be clear, in the whole history of pharmaceuticals, that's essentially what people have been doing. So I think that's really likely to change quite dramatically. We've heard a bit about cancer. I want to just say a little bit about cancer because, again, it's become a bit of a poster child of precision medicine. This relates to drugs, but it also relates, just to remind you, about the way you use radiation oncology, about the way you treat patients with minimally invasive surgery. This is a picture of the signaling cascades, the generic signaling cascades in most cells, including cancer cells. You can see that there are a host of interesting potential targets there. Many of them have cancer mutations and amplifications, the tyrosine receptor kinases, as well as a variety of the kinases involved in the signaling factors down the various signaling pathways. There are, of course, lots of diagnostics available for all those, but there are also now drugs available to treat almost all the relevant molecules in those pathways. And they're being used with some, not complete success, in the cancer arena, but it has given rise, I think, to the belief that there's no point in blasting away at cancer without having a really clear understanding of the genetic fingerprint that underpins the disease you're trying to treat. Understanding that there are additional complexities about tumor evolution and the likes. But I think this has been a good example of how that field has evolved. And we here, like many others, have developed gene tests, which are basically characterizing hotspots or variants in genes that might be relevant. But what's striking about that is that in diseases like non-small cell lung cancer, you get quite a substantial number of patients where the information you get is clinically relevant and clinically applicable. And our experience is the same as many others. This is Anna Schu's work in our pathology lab. And in hematology, that is at least as important. In red cell disorders, you get 32% of the patients have some genetic variant which is clinically useful. In myeloid disorders, that's about 38%, and in lymphoid disorders, it's slightly more than 40%. So I don't think this is any longer an option for people who are trying to be at the cutting edge of malignant disease. You really do need to understand much more precisely what the tumor is doing. And I think with the advent of whole genome data in tumors, which has, I accept, been slow coming for a whole variety of technical reasons, there's going to be a host of other opportunities to pursue in that space. I also, though, wanted to just make the point that although the big driver and the engine, I think, for the precision medicine story has been genetics and genomics, it's very important not to forget that these days there are powerful sources of data from pathology, and in particular digital pathology. There's also powerful information from things like immune monitoring and other approaches for systematically characterizing different analytes and biomarkers in patients. And they all, I think, have to be incorporated in a broader strategy that's tackling the problem of precision medicine. So I just wanted to give you a good example of that, because this is an example which is a non-genomic example, and I know you're mostly genomic scientists, but I just wanted to calm you down to say that there are things out there which are not related to nucleic acids even. And the field of asthma, as you noticed on my first slide, 40% of people are non-responders to conventional asthma therapy, may even be more than that. And for many years, in fact, it's been 20 years since a new, really novel drug for asthma has been discovered and developed. And the reason for that is whenever you give it to a whole population, it doesn't work very well. And the reason is it's a heterogeneous population. And this guy here, who's Ian Pavord at Leicester, I think was responsible for the major breakthrough in this field, which was redefining the disease into two major population subgroups. One is an inflammatory type of asthma, which was associated with high circulating eosinophils, high eosinophils in the bronchial tree, the presence of periostin, which is a protein which is overexpressed in cells in the bronchial tree, high levels of exhaled nitric oxide, and an increased activity in Th2 type T cells, where there's and that's about half the asthma population. And the other half of the asthma population doesn't have any of these inflammatory markers, or they're below some threshold. And the impact that's had is quite interesting. And this is a good example. This is an example around a new asthma therapeutic, which is called the Co2H2 inhibitor. And you can see that the difference in the responses is FEV1 response in people treated with this agent or not treated with this agent, the improvement if you have a high blood eosinophil level rather than if you have a low blood eosinophil level, and the dramatic difference in response. And that, I think, was the first demonstration. This was driven by Ian Pavord, who said, hey guys, you better look at the high eosinophil population because you won't get a result if you don't. And he was absolutely right that that was a distinguishing factor. And since then, many other companies, and again, this is lebrikizumab, which is the IL-13 antagonist, shows exactly the same thing, and that is high periostin, essentially high eosinophils. That's the total cohort, and this is the low eosinophil population. You can see quite dramatic differences in therapeutic response. Now, okay, so so you've defined the disease. Now suddenly you get drugs that work. And on the back of that single observation, these are all the new drugs which are now very likely to be approved based on that simple observation. So this becomes a huge obstacle if you don't work this out, if you're trying to develop new therapeutics for patients with disease. And I think asthma is a perfect example, and I'm sorry to say it's not a genetic test. Let me talk a little bit about rare disease, because I think it's another example where genetics and genomics has proved to be hugely powerful in understanding underpinning mechanisms of disease. And the example I want to show here comes from our own local study, which is the WGS 500 study, which was done in collaboration with David Bentley from Illumina. It was led by Gil McVean and Peter Donnelly, and Jenny Taylor from Wellcome Trust Centre from Human Genetics. I was involved in the project on its advisory board. And the intention, because it started in 2011, and we were approached, in fairness, and David can correct this in his talk if I'm wrong, but we were approached by Illumina, who said, we're not sure whether this is ever going to play in the clinic. And we said, well, actually, why don't you do the experiment in a clinic, and then you can tell. And the experiment was very simple, and that is, why don't you ask the doctors in a big general hospital, specialty services, send us some people in whom you think there's a genetic problem, and we'll do whole genome sequencing and see if we get the answer. And I think even those of us on the steering group who are on the whole huge advocates for this strategy were surprised by the positive nature of the output that we got, because these were patients who'd been screened for every known genetic variant that was known to be associated with those diseases, and in many cases came from extreme phenotypes, came from others were Mendelian disorders, others were sporadic cases that were likely to be de novo variants. And this is the output of that, and I can't go through this in great detail except to say that there were a wide number of different diseases, as you see here, and you can see that in there we found all kinds of different things that included new genes that had never been seen before, that included genes that had been previously described with other phenotypes that were now described with these phenotypes. We described known and existing variants that were apparently screened before we looked, but when we looked again, they were actually there in those patients, and a very large number of interesting candidates that are still being worked through a cohort of scientists who are busy pursuing those. So this, I think, revealed to me at least that there was this was providing huge benefit to patients, particularly to patients with children who had been through a diagnostic odyssey around the country to be diagnosed over many years. And this is a good example. This is the disease. We too have a passionate leader at the moment who's in the form of David Cameron, who really believes in this. And he had a child who had this disease. And at the time that child was diagnosed, nobody knew what the cause of the disease was. One of the things that emerged from this study was a whole set of trios with Ohtahara syndrome. Interestingly, they all have completely different genetic variants. So again, this problem of phenocopies is a real issue for diagnostics and potentially for therapeutics. So just very briefly, I've got a couple of minutes left, where you can see that this is now beginning to really play in a whole variety of different domains. It's going to lead to this issue about what do you do with all the data, how do you collect it, and how do you make it work. And we're building this building right next to Peter's Wellcome Trust Centre for Human Genetics. Half of it's already built. This is the Target Discovery Institute, Peter Ratcliffe's building. This will be housing about 600 people whose interests are in the analysis of these types of data. And we have some very substantial experience bringing large data sets together in a controlled setting. And Rory will be talking to you tomorrow about UK Biobank. But I really do think this is a terrific model about what can be done within the NHS. And just to remind you, 500,000 participants with a whole set of interesting measurements taken on onset, and then a variety of different subsets with different detailed phenotyping going on. Retinal images, visual acuity, hearing tests, vascular reactivity. And I think also more recently, multimodal imaging, which we will do in 100,000 people. That project has just finished its pilot phase. And this, which Peter Donnelly has been very involved in, is the genetic SNP analysis using an 820K chip for an analysis across the full 500. And Tim Peatman, who I caught just before, said that they're on the verge of having all that data available, which will again be really exciting. So this is really big data, but we also have this remarkable possibility with that sort of number of the incident cases of these diseases which are emerging over time, which you see will give us really big numbers of patients to study. So I think biobanking, in a sense, is a hugely powerful exemplar. Genomics England is another very powerful exemplar, which I've left for John Chisholm to tell you about. But then there is this other issue, and that is, how do you capture electronic patient records for precision medicine, as we call it, in the wild? And by that I mean using real hospital records, dynamic data, stuff going in and out all the time, dealing with a whole set of issues, governance issues, interoperability issues, the functionality issues of the software, but also the data quality issues. And that's an area where I don't think anybody is in a good position at the moment. We're finding at Genomics England that this is hard. At Biobank, we're finding even in an established setting, it's really hard. And I think that's going to be one of the big challenges in the future. So just to show you where that takes you, when you start studying, next one please, and next one please, this is some work which Kazem Razimi has been doing, looking at real large-scale patient data, up to 4.5 million patients. And these are the confidence intervals you get in the correlation between systolic blood pressure and heart failure in different age groups. And you can see that these are the different age groups. And when you start with 40,000 patients, which you may see a lot, the confidence intervals are all over the shop. As you get to 400,000, things start to look a lot clearer. But then when you get out to 4.5 million, you start to get really precise and powerful examples. And I think that shows the kind of power that exists in these large-scale patient records, real patient records in the wild. But to be absolutely clear, data quality, data validation, really, really hard in that setting. But all this will be necessary if we're going to take the precision medicine agenda forward. So thank you very much. I think I'll end there. Thanks.